Hello, I'm Ajay Aggarwal. I'm a consultant clinical oncologist at Guy's St Thomas's NHS Trust and an associate professor in health services research and global health at the London School of Hygiene and Tropical Medicine. Been asked about services and systems research to inform national cancer control plans, and really I think they're very important for addressing four fundamental gaps. There's an evidence gap, there's an implementation gap, there's an equity gap or an access gap, and there's an outcomes gap as well. And I'll explain both why these are important in terms of improving outcomes and affordability and equity at the population level, but also how these are actually key research questions requiring quite robust methodologies to actually answer them formally in order to inform national cancer control plans. So if we take the evidence gap, we sort of take as a mantra, we need randomized control trials or real world evidence is very good, but it goes beyond that. Have we asked the right question? Have we designed the study in the right way and used the right data for it? Are we using the right endpoints? There's a lot of, are we able to show whether a new intervention or drug improves the quality of life or the length of life? Have we taken patient-centric outcomes within that, so patient-reported outcome measures, and also cost and affordability? So these are many things, and many of the issues that we often have is because we haven't actually developed the adequate evidence in order to support implementation, not just in the high income setting, but in the low middle income setting as well, especially. And that's why there's often a difficulty in integration or silos of care. The other factor is actually in many studies, the population is not representative of the population actually treated in the real world. And that disconnect can often mean that studies which show marginal benefits in randomized control trials show no or little benefit in the actual real world. And so we have to have an adaptation to the actual populations that are required. So I think there's a lot that needs to be done. I think the value-based healthcare frameworks that are coming that are trying to raise the evidence bar, not just for medical oncology, but also radiation oncology. So I think evidence is a fundamental area to focus on. So for national cancer control planning, are we advising those interventions that are going to meaningfully improve outcomes, or at least have evidence for that effect? I think the second thing is the translational gap. We spend so much time on innovation, biotech, but very little on actually implementation. And the reason why that's important is that only 50% of innovations that we know that work and have a robust evidence base actually get into clinical practice. And it can take up to 20 years to do so. So what are the areas for that? Well, there's professional consensus. Do people agree? Often they don't. There's often differences of opinion. There's the regulatory hurdles. Can it get through those hurdles and seen as a safe device or drug? There's reimbursement. Who's paying for it? Does it need to go through health technology assessment? What are the sort of broader funding for those drugs? Is it through patient out of pocket? Is it funded through the actual health service itself, or is it only available at private providers? So these are all elements that need to be understood and exposed, the barriers and facilitators through implementation research to understand this better. So I think that is a major area where we just think that actually, if we develop all this amazing innovation, it will suddenly get to the patients themselves, but we can see that there's a failure to do so, but that's because there's a failure to research how we adopt new innovation. I think the third bit, which I think is important, is the access gap. It's sort of a given, we hear about it, patients who actually require treatments not having access to this, and often tends to be lower socioeconomic groups or elderly groups or marginalized groups to some description, whether it's also from different ethnicities or parts of a given country. And we need good epidemiological research to understand the clinical epidemiology. And then we need to understand, once we've seen what the issue is, why is this issue occurring? On a very broad basic level, is it due to a lack of availability of equipment or workforce? That in itself needs research to work out actually what is the actual resource need to meet the current need and future needs. So lots of modeling work with regards to that. Then there's an element of what is the system for understanding what is the best interventions for patients. So that's evidence-based guidelines. Do we understand whether they are available, and also are they being used adequately? Then there's access. How do people access services? How are they referred? Can they actually get to the treatments themselves? Do they need help with transportation, accommodation? Do we need to increase the accessibility more locally? So I think those are all factors, and we sort of move to, we need to improve outcomes, we need to centralize, but actually understanding the trade-offs that will occur with regards to patients actually getting and receiving that treatment is profound. And I think work done from national audits in different countries can show that actually the same patients with high-risk disease, so an example from the National Prostate Cancer Audit, there's a 50 to 90% difference in whether a patient with high-risk prostate cancer actually gets a radical curative treatment. Huge gaps potentially. Equally, if you don't live in a centre that offers surgery and you're diagnosed, and if you're diagnosed at a centre that doesn't offer surgery or radiotherapy, you're less likely to get those treatments. So there's a lot to be done. I think the final gap, and that's poorly understood, is the outcomes gap. We think that actually if we follow the recipe, we're going to get the same outcomes across the board, but we know that even when adjusting for different aspects of the patient, whether it's their comorbidities or their age or their socioeconomic status, different patients receiving the same treatments, the same recipe, get different outcomes. And this speaks of performance and benchmarking of best practice. And I think this needs to be centered on the professions themselves. Now, there's a lot of work being done previously, particularly in the 90s, as to how do we motivate performance or look at quality improvement and quality assurance. I think first and foremost, we need good quality data, and that needs to be presented at the right level, the hospital level or the individual physician level. We then need to understand how do you go about improving, so benchmarking of care, understanding an agreed consensus or guidelines towards that, and we need that feedback as well to see whether there's improvement. And now so the surgeons are ahead of the curve in this regard for a number of years, and now increasingly cancer surgery, whether it's in urology or bowel cancer, for instance. However, we've now set up, particularly in the UK, benchmarking for radiotherapy outcomes and now systemic therapy outcomes. And the first thing we see is quite a lot of variation in performance across centres in the UK. But then when we nail down into actually what the reasons are, it's not because people aren't doing the right thing, it's just that they're not evolving their service. And this goes beyond the need for clinical trials. And so we need to understand how we can motivate this. Different elements that come into it are health system design. So do we say, well, actually, we need to create centres of excellence, we need to centralise, so we have all the specialist expertise, people are doing a high volume of procedures that improves outcome? Or on the reverse, do we need to motivate people through market incentives? And I think one of the big things globally, and this informs national cancer control plans, is that we have healthcare markets essentially with information asymmetry. And what I mean by that is actually people are moving around for care to centres which they think deliver better outcomes, but don't actually know what those outcomes are. And if we had good information on quality of services, then this could create the infrastructure required for boosting performance across the board. So for me, those are the key access gaps that health systems research can look to research and develop interventions for. So around evidence, around translation and implementation, access and outcomes. And these are core ingredients for the national cancer control plans. The thing to mention, though, is that currently in terms of research outputs, this only constitute this area about 3 to 5% of all research. At the moment, 50% is focused on systemic therapies, genetics, biomarker work, and a small proportion to the fundamentals of actually someone receiving that treatment and getting a good outcome from it, and how it's funded. Is poorly resourced, and we need to have greater funding for this. And I think that's a need both from federal funders and also private funders where necessary.